There we go. Great. So, hi guys. Hi everyone who's here. Happy Friday. Everyone who is watching this later. Glad you're here. Vanessa and I met, oh gosh, it's probably been about 2 months now, maybe 2 months ago, something like that.
Yeah.
We were at an event in Seattle, like a BIPOC leadership event, and we had a glass of wine in our hand and started chatting, and I got to hear about her and her career and work and just immediately was interested, and then connected her with Emily here. Hi, Emily, who is really interested in working with women during this season of the lifespan. And as we got to talking, just really noticing, I mean, gosh, this topic affects 60% of the people that come in the door at Self Space that identify as female. So just really excited to hear from her. And Vanessa, you can go ahead and kind of take the floor and introduce yourself and tell us about yourself and kind of how you got here.
Yeah. I'm Vanessa Weiland. I'm an adult gerontology nurse practitioner. And I've been practicing over 10 years now, but I haven't been focused in menopause this whole time. And I'll go through that just a little bit. But now I'm doing menopause care holistically and specifically. I have 2 locations in the Seattle area for my menopause clinic, Phases Clinic. So one is in North Bend, just east of Seattle, and the other is in Shoreline, just north of Seattle. I'll go ahead and share my screen. Oh, I think I need permission to share my screen.
You know what? Oh, let me get this. Okay, hold on. Just 1 second. I need to figure out that permission. 1 sec. How did you end up focusing on, while I do that, tell us how you kind of got interested in menopause. How did that all happen?
So I'm a little embarrassed to say that after my nurse practitioner schooling, which was very light on the menopause education, I didn't reevaluate that. And I was taking care of a lot of menopausal women, as you can imagine, and perimenopausal women working in adult gerontology care. And now I just grieve all of the women that I discouraged from using vaginal estrogen, not understanding that it's safe for practically everyone.
Okay, lovely. Do you have all the permissions you need now?
Yes, I think so. Is it showing up for everyone else?
It looks great. Yeah.
Okay, perfect. So I even have a little timeline explaining how this all happened.
Oh, neat.
So I actually did neuroscience first off and did neuroscience research for a couple years. So that has really helped me with navigating the research in menopause because it's scant in a lot of areas, and it can be tricky to determine what to believe and what not to believe. And then I decided I wanted to go back to school for nursing. So I got a second bachelor's and then a master's in nursing. I mentioned that was adult gerontology, primary care. And then at that point, I had maybe 1 hour of menopause education. So 10 years later, I'm driving in my car doing home health as an NP and listening to a menopause podcast, a medical podcast, and a menopause specialist came on. And I had this eureka moment because I was realizing not only did I learn almost nothing in my nurse practitioner program, what I did learn was so out of date and wrong. And I personally will be going through this before too long. So I really decided I need to beef up on my knowledge there. So since that time, I've taken a lot of additional training, specifically in menopause care. I got trained in clinical hypnotherapy, specifically with menopausal patients in mind. And I'll discuss that a little bit later, how that's used in menopause. And now I've opened my own menopause clinic, Phases Clinic, and I'm a Menopause Society certified practitioner. So I've come a long way in just the last year since my eureka moment. So today I want to briefly review the physiology of menopause and then talk about common symptoms, including mental health symptoms, and then talk about evaluation and treatment, just so you feel a lot more confident with these patients moving forward. And I like, Rachel, that you mentioned that not everyone who experiences menopause considers themselves a woman. So I do try to be thoughtful about that in my language, but at times the research is specifically looking at women. So I'll say women in those cases. So I'll try to keep things relatively light today and engaging, but I do want to mention that menopause, it's no trivial matter. I know in the media, it's usually just a punchline, but it can have big ramifications for your personal relationships, your work life, and even your relationship with yourself. So a lot of relationships, marriages that end in this time, the woman might blame menopause partly on the divorce. 2/3 of women report that menopause severely disrupts their workplace challenges
Mm.
or create significant workplace challenges. And then the suicide rates are actually highest in women between 45 to 64 as well.
Mm.
So menopause, the definition is actually just one day in your life. It's the day that you went 12 months without a period. Not everyone is having periods, so of course we might need to use labs or some other methods to figure out menopause for some people, but for most people, it's just a clinical diagnosis. On average, it might range anywhere from 45 to 55. Of course, there are people outside of those ranges, but that's the vast majority. And the average age is around 51. And then for some people, perimenopause, which is the period of menopausal symptoms leading up to that final period, that might not be noticeable at all. I'm sure you've all heard of people that really didn't notice menopause symptoms. And then for others, it can last over 10 years. So the average I've heard is about 7 years leading up to your final menstrual period that you might start having symptoms. So perimenopause, I mentioned, is the symptomatic phase leading up to menopause, and then postmenopause is the whole rest of your life. So unfortunately, you never really escape it. And I won't focus on this too much, but just want to remind you that every month you have these cycles of your sex hormones, estrogen and progesterone. So the estrogen ramps up in the first half of the month to help you ovulate your egg. And then progesterone ramps up in the second half of the month to help build the lining of the uterus. And when your body realizes that there hasn't been any fertilization, the progesterone goes down, and that's what stimulates the menstruation to start. And there's a feedback loop, the FSH and LH, those are a feedback loop of your brain and your estrogen, which helps to keep this cycle going every month. But over the course of your lifetime, there's even larger changes in these hormones. So I put everything on the same scale just so you can compare the amounts of each hormone that you have in your body, but that means progesterone is just this tiny little blip at the bottom here. Estrogen is literally off the charts if you ever get pregnant, but otherwise it's quite a bit higher than the progesterone levels. And actually testosterone for most of our life is the highest level of all. And that's because partly because testosterone is converted into estrogen. So these levels ramp up from puberty into your 20s or so, and then testosterone starts to ramp down again sometime after your 20s, but it's a pretty steady decline for most people. The progesterone, so as your testosterone remains relatively high compared to the estrogen and progesterone, you can start to see actually some symptoms of high testosterone and early perimenopause, like acne, oily skin and hair, hair loss where you want it, and other hair where you don't want it. And then as the progesterone goes down, which tends to precede the estrogen changes by a little bit, that's where we see a lot of insomnia and anxiety, because progesterone naturally in our body tends to help us with sleep. And then the estrogen is a little bit more of a wild card, because as that feedback loop is happening between the brain and the ovaries, but your ovaries are producing less eggs, things really go kind of out of whack, because one month you might have no egg ovulated. So FSH in your brain says, oh goodness, we got to really crank things up. And then the next month you might have double the normal estrogen and 2 eggs come out. So whenever you have those high estrogen months, you can have a lot of breast tenderness, and your periods might get heavier, longer, closer together. So that surprises a lot of women, because they think of menopause meaning less periods or lighter periods, but in the beginning, it's actually the opposite. And then as those estrogen levels are going up and down, it can cause a lot of mood swings, and those particularly low levels are going to be what triggers hot flashes. As you reach the end of perimenopause and postmenopause, things start to stabilize, but now they're just stably low. So that can cause ongoing genitourinary symptoms like vaginal dryness and recurrent UTIs. So I have a case study here. Mrs. Cho, a 47-year-old Korean American woman with a history of sleep apnea, irritable bowel syndrome. She presents with fatigue, anxiety, weight gain, hot flashes, hair loss, muscle aches all over. Her primary care provider did order an antidepressant, escitalopram, but she decided to stop it on her own because it was making her nauseous. And she hasn't been using her CPAP for sleep apnea. She's a full-time caregiver now for her husband after a stroke at a young age, and she's feeling overwhelmed. She's still having regular periods. She's not sexually active. She doesn't smoke, use drugs, or drink. For medications, she's taking supplements and then some as-needed medications for the irritable bowel syndrome, pain, and heartburn. You don't have access to her labs, but she says that her thyroid was normal when it was checked, and she doesn't have anemia, but her iron was on the borderline low side, so she tried taking iron, and it didn't help her symptoms. And then her vital signs exam are all pretty normal. Her PHQ-9 score is 10. So my plan for her, first off, is try to encourage her to use the CPAP again, because that's, of course, feeding into her fatigue and poor sleep if she's not using her apnea machine. And if it's been a little while since those labs were done, I'd either try to get access to those labs or maybe you just recheck them, recheck the thyroid, check again for anemia, the metabolic panel if there's any electrolyte deficiencies, kidney disease, liver disease, things like that. And then because she's having these body aches, I'd probably look into an autoimmune condition like rheumatoid arthritis or lupus. Maybe checking zinc and vitamin D, those can cause hair loss when those are low. I definitely am concerned about this depression and probably off the bat would think about replacing the antidepressant with something she might tolerate. But I also might think, first of all, about menopause care. And I'm not naive enough to think that we can just give her 1 or 2 medications and treat all of her symptoms, but how nice would that be if we could just use 1 medication, or if you have a uterus, 2 medications to treat the hot flashes, the hair loss, the body pain, fatigue, anxiety, and even actually irritable bowel syndrome symptoms can get worse in perimenopause. So since she's still having regular periods, some people would say she's not technically in perimenopause. Some would say she's technically in what's called late reproductive stage, but the treatment is not different. So I'll just call it perimenopause because I believe that some of her symptoms are due to this stage of life. So I'm sure that you have maybe personally experienced or had patients who experienced going to a provider saying, I think I might be in perimenopause or menopause. I'm having these new joint pains, or my mood is off, or anything but hot flashes. They probably will say, I don't think that's menopause. But this is the menopause rating scale. It is a validated measurement used in research, and you can see right off the bat, it has hot flashes, but it has heart palpitations, trouble sleeping, changes in mood, joint pain, bladder issues. So I think this is a really great tool. You can find it for free online and just tell your patients, you can print this thing out, they can bring it with them. Just as a way to start the discussion if they find that their provider is not too well informed or resistant. And I personally use this in every visit so that I can assess response to treatment. And it's not just those 11 main symptoms. You have receptors for estrogen, progesterone, testosterone, and practically every cell in your body, head to toe. So I've heard of all these symptoms and more. And I'll give you a second to kind of look through some of those, see if anything resonates.
I've never heard of burning tongue. What is that?
Yeah, it's almost like a nerve type pain. And a lot of these, there's practically no research on it. So you'll hear anecdotally that hormone therapy worked for some of these, and then other people say it didn't work. A lot of the nerve pain seems kind of 50-50, but you can get nerve pain in the fingers, toes, the burning tongue. People will say their body odor changed. Chronic cough, I didn't realize. So it's really head to toe. And I just want to point out a study that came out earlier this year in 2024 that asked women in perimenopause, would you say that you don't feel like yourself? And 2/3 of them said, I don't feel like myself at least half the time. So in some ways, this is not the most useful measurement, but I do think it's kind of reassuring, because if you're in your mid 30s to mid 40s and you just don't feel like yourself, I think there probably is really something going on there. Specifically around mental health, there's actually a new study that just came out this month looking at rates of depression and bipolar in perimenopause, and they found a 30% higher risk of depression. Another previous study had found a 40% higher risk, so somewhere in there. The risk for mania and bipolar went up 112%. So that's really dramatic. They didn't find any relationship with schizophrenia. And then, although anecdotally, we hear a lot of women saying that their anxiety is worse, there hasn't been a ton of research on this, but it seems like the women who actually didn't have anxiety previously might be more susceptible versus those who had it previously. It might be a little more stable. And then fortunately, postmenopause, it tends to look more similar to premenopause. ADHD, once again, almost no research on this, but I have found some studies looking at more of the monthly menstrual cycle, and that during PMS period, when estrogen and progesterone are lower, the response to psychostimulants can be lower. And then, as you saw in the previous slide, a lot of people, whether or not they have ADHD, notice brain fog and trouble concentrating. And so that can really be ramped up during this time. Treatment options for mental health. One study found that mental health therapists that specifically focus on resilience and self-efficacy can help during this time. The first line treatment is still going to be medications for mood disorders. However, there have been several studies and growing studies showing that hormone therapy can be an effective treatment during perimenopause for new onset or worsening depression and anxiety. It would be off-label for that. But that being said, a lot of people have been using antidepressants off-label for hot flashes for a long time, so don't feel that bad about that. And then mindfulness interventions, so maybe yoga, meditation, hypnotherapy, things to reduce stress and improve overall well-being. And then support groups can be really helpful. I know several online ones. I don't know any local ones, so if your group ever wanted to create something, I'd be happy to be there as a, support for medical conditions. And I never want to lose the fact that a lot of other things can imitate menopause. So as a menopause specialist, I can sometimes be guilty of being the hammer, everything looks like a nail, right? Where everything looks like perimenopause and menopause. Thyroid disorders in particular are really good at mimicking perimenopause because it can cause changes in your hair, changes in your weight, changes in your temperature, and irregular periods. So that's always one that I want to rule out, particularly if someone's presenting to me on the younger side. And then other conditions are more likely to mimic certain pieces of this, like depression, anxiety, anemia can cause fatigue, diabetes can cause urinary frequency and fatigue, polycystic ovarian syndrome, that can cause irregular periods, some of those high testosterone symptoms that I mentioned, vitamin deficiency, sleep apnea, and also medications, once again, more likely to mimic just certain symptoms like fatigue or hot flashes. Opiates can cause hot flashes, steroids can cause weight gain. Chronic stress can simulate menopause, and part of it is that it's directly affecting the brain to ovary axis. But some of the symptoms are just similar overlap as well: poor sleep, hair loss, weight changes, things like that. So I asked an online support group of women in perimenopause and menopause, if you could wave a magic wand and make your biggest menopause challenge disappear, what would it be? So I didn't want to know what's the thing happening the most often, but what's the thing that is just driving you the most crazy that you just really wish could disappear. So I don't know if anyone here wants to guess what the number one thing was. It wasn't what I guessed. No. Okay. The number one issue was weight gain. So hot flashes was there, trouble sleeping was there, pain, things like low libido, vaginal dryness. But the number one thing that people really wished they could just disappear is the weight gain. So I'll focus on that just a little bit. This abrupt change in your body during perimenopause, a lot of people call it menobelly. But basically, as your estrogen levels go down, your composition changes. So you might not necessarily notice a change on the scale of numbers, but you're probably losing some muscle and some bone. And also your fat is redistributing from your hips and your butt up to your belly. And then if your testosterone is on the high side, that can also cause more of a beer belly type look. And high cortisol can also cause increased weight around the belly. So all of these are kind of contributing to cause this change in your body composition all around the same time, sometime in the 40s usually. Actually, I kind of find it kind of fascinating because it's probably an evolutionary adaptation. Our fat cells can create estrogen, and it's not estradiol like our ovaries make, but it is another form. So maybe this is our bodies trying their best to help us with our hot flashes. But I understand why it bothers people. It's not just the way it looks, it's also a concern for metabolic issues like diabetes and heart disease. When your sleep is disrupted in perimenopause, that feeds into this as well, because when you sleep poorly, it affects your hormones for your appetite, ghrelin and leptin. So you're more likely to have an increased appetite. And although hormone therapy can help with the body composition change, it doesn't normally help with weight loss in and of itself. If it helps you sleep, then you're more feeling more motivated the next day, and you to exercise and um, eat more nutritious meals, then it can help with weight loss in that way. But it doesn't do it in and of itself. And there was a study looking at the combination of hormone therapy and GLP-1 receptor agonists like Ozempic and all of those. And the two seem to work even better together than they do separately. So it's kind of like the 1 + 1 = 3 type of thing. So if you have someone that's considering a medical option for weight loss, that's something to keep in mind. And then long term, anything that you take, whether it's a medication, any sort of diet, um, it's not going to have the long term impact on your weight unless you can stick to these long term management pieces like your nutrition, physical activity, managing stress, staying up on your sleep hygiene. And then I also think even if you find a diet that works for you to lose weight, if you're coming at it from a place of hating yourself, I don't think you're ever going to find long-term success. So I think self-compassion has to be a really big piece of this. So when I talk about hormone therapy, a lot of people think immediately about cancer or maybe heart disease and have heard that it's dangerous. And that's what I learned when I was in school as a nurse practitioner. The interesting thing is in the 1980s and 1990s, a lot of women in the US were using hormone therapy. It was over 42%, or sorry, over 40% at the peak from what I could find. And then in 2002, it all came to a crashing halt. And the most recent number I could find was 2019, was less than 4%. So what the heck happened in 2002? There was a study that was the largest ever randomized control trial looking at hormone therapy versus placebo. And their theory was that hormone therapy would decrease the risk of heart disease because a lot of observational studies were showing that. So they took women of any age post-menopause. The average age was
Oh, just a sec, Vanessa. I think you muted.
and they found a higher risk of breast cancer. So it was a little unusual. They sent out a press release about the halting of this study before they analyzed all the data. It was strange. And there's now conspiracy theories about why it went down like that. But basically, there was mass hysteria, and women were literally flushing the hormones down the toilet, um, and suing their doctors and things like that. So that kind of killed off hormone therapy for a little while, but luckily some researchers did go back through that data and look at women who were between 50 to 59. Those are the women that were actually most likely to treat with hormone therapy, right? The ones that are closer to menopause, more likely to be symptomatic. And in that case, they found that there was overall, once again, a lower risk of heart disease. When they broke it into the two groups, this is whether or not you have a uterus. So if you don't have a uterus, you can do estrogen only. If you do have a uterus, you have to combine estrogen with some sort of progestin. And I don't know if you can remember from earlier in the talk when I was talking about how the progesterone decreases the lining in your uterus. And so you need that balance when you have a uterus. So the estrogen only group, things look great. There was a higher risk of blood clot, but a lower risk of heart disease, breast cancer, colorectal cancer, any type of cancer, all over overall cancer risk.
Vanessa, can I quick
Uh,
interrupt you and ask a question?
yeah,
Your mic actually cut out for a quick second, right at the peak of
okay.
when you were saying what the study found, and we just missed like a minute. Can you say, I think you were saying heart disease. The study found that heart disease increased. Is that right?
Yeah, yeah.
Okay.
So
Can
the
you
risk
please
of
repeat
heart
that one time
disease,
so we can make sure we get it?
yeah. They stopped the study early because they actually found an increased risk of heart disease. And there was mass pandemonium. People were flushing their hormone therapy down the toilet. And luckily, some of the researchers did go back and look at this study in a subset of women between 50 to 59. These are the ones that are probably more likely to be symptomatic. The group that is more similar to how we normally use hormone therapy. And in that group, they found a lower risk of heart disease again. When they broke it into estrogen only versus estrogen plus progesterone, they did find that the estrogen only is more beneficial. Um, and if you don't have a uterus, you only need estrogen. If you do have a uterus, you need to counteract the estrogen and the progesterone so that your lining in your uterus doesn't overgrow. So in both groups, the risk of death during the experiment was lower. The risk of fractures is much lower because estrogen is so important for bone health. The risk of diabetes is a lot lower. The risk of colorectal cancer is lower, and the overall risk of cancer is lower. So, yes, there are these concerns here with blood clot in the estrogen group and with heart disease, stroke, and breast cancer in the estrogen plus progestin group. But you can see that overall, even that initial study that brought everything to a crashing halt really didn't look all that bad. And then I just want to point out that the risk of breast cancer, where it was higher in this subset of women, it was 6 additional cases per 10,000 women per year. So for some people, that's a deal breaker. For others, that might not be. And I think we really lost the piece where we keep women involved in their own decision making. And I just want to focus on the blood clot risk because that was the main risk for the estrogen group. And that was about 10-ish additional cases per 10,000 women per year. And that everyone in that study was on oral estrogen. But actually transdermal estrogen, where it goes through the skin, hasn't been shown to increase the risk of blood clot at all above your baseline. So that's why I typically start with that first. And the risk of blood clot, if you do oral estrogen, is highest within the first year, and then doesn't seem to be a big increase. Now, earlier in your life, you might have been on oral birth control. There's no gatekeeping around oral birth control, of course, and that's a similar risk of blood clot. If you ever get pregnant, that's a higher risk of blood clot, and particularly in the postpartum period, a much higher risk of blood clot. So I don't know if you've ever heard of someone that was discouraged from getting pregnant because their aunt had a blood clot, but I think that we do value fertility over quality of life. in the perimenopause and menopause years. The FDA-approved indications for hormone therapy are vasomotor symptoms, genitourinary syndrome of menopause, to prevent osteoporosis. So if you have osteoporosis in your family or you currently have osteopenia, you may be able to get FDA-approved hormone therapy, have it covered by your insurance, all of that, even if you don't have symptoms. And there's a online score calculator for your osteoporosis risk called the FREX score, and it's just a free online calculator. If someone goes into menopause before the age of 45, whether that's from surgery, from medical treatment, from premature ovarian insufficiency, it's considered standard of care to treat them with estrogen up until this average age of menopause, at least up until the age of 51, because otherwise there are much higher risks of osteoporosis, heart disease, and dementia. The Menopause Society is the largest medical society that puts out position statements on conditions related to menopause. So they had an updated position statement in 2022 about the use of hormone therapy. And they say it is the most effective treatment for managing vasomotor symptoms and genitourinary symptoms. And ideally, if you initiate within 10 years of menopause and or before the age of 60 or so, the benefits would outweigh the risks for the reasons that we spoke about, with it being lower risk of heart disease if you start earlier. And of course, we should be individualizing this based on each person's individual health status, benefits, and risks. And there should be collaborative decision making between the provider and the patient, which doesn't always happen around menopause care. Who's the ideal candidate for hormone therapy? Someone that's normal weight, within 10 years of menopause, no metabolic issues, normal blood pressure, and no increased risk for heart disease or breast cancer. Someone who maybe they currently smoke or have diabetes, high cholesterol, visceral weight in the abdomen, high blood pressure, autoimmune disease. That's really concerned with blood clot. And there's a risk calculator for heart disease. So if that shows up as moderate already, or maybe they have a family history of breast cancer, then you can, none of those have contraindications for hormone therapy. It's just a more nuanced discussion. And then who's considered not a candidate for hormone therapy is someone with active liver disease, history of stroke, artery disease, history of blood clot, heart disease, estrogen sensitive cancer. If someone has unexplained vaginal bleeding, it just means you got to sort that out before you can start hormone therapy. It doesn't mean you can't ever do it. And I put a little asterisk at the top because for me personally, I will consider the benefits and risks for even anyone that's in this group. Like for instance, you had a blood clot, but it was after surgery and considered provoked. And can we think about transdermal estrogen where there's no increased risk that's been found? So I'm more than happy to have that conversation with anybody, really. We're not always going to choose hormone therapy, but I do think people deserve a conversation. Some common symptoms of hormone therapy, one of the big ones is if you bleed, and that's where we need to figure out the balance of estrogen and progesterone, and that usually can be resolved, but depending on the situation, we might need to do further testing to rule out endometrial cancer. Breast tenderness can come on with either estrogen or progesterone. If you think about when you're in PMS, a lot of women have breast tenderness with the high progesterone. So that might resolve on its own or with adjusting the dose. A GI upset, that's most common with oral progesterone, and we have ways to work around that, but it also might resolve on its own. And then moodiness, that can happen with estrogen, progesterone, testosterone, any of those if we're too high. So if it doesn't resolve on its own, once again, a dose adjustment can usually help. But just letting people know that it might not be an overnight process. It might take a few months to really tweak things and get it right, where we're effectively treating menopause symptoms without creating a new list of problems. So you've probably heard the terms HRT, BHRT. What are these? I personally call it menopause hormone therapy, but it's all the same. HRT is hormone replacement therapy, replacing estrogen, progesterone, sometimes testosterone. And typically when people are talking about HRT versus BHRT, they're talking about the synthetic ones or the ones derived from horse urine, that's Premarin. And then the ones that are made in a lab but designed to look exactly like what your body makes are bioidentical hormone replacement therapy. Truly, it's basically been used as a marketing campaign to say it's more natural. We don't have great head-to-head studies showing that it is safer, but a lot of providers, even a lot of providers that are menopause specialists, do think that it might be a little bit safer. So oftentimes that's where we start. But you can easily get FDA approved bioidentical hormone replacement therapy. So a lot of the patches that are available at your local CVS are going to be bioidentical. So if it says estradiol on it, then it's bioidentical. Progesterone that comes in a oral capsule, that's bioidentical. And then testosterone, once again, you can easily get a bioidentical FDA approved option. The only problem is it's going to be one that's made for men because there's no FDA approved option for women in the US yet. So basically, the Menopause Society, American College of Obstetricians, Gynecologists, all recommend against compounded and pellet BHRT. There are cases where I might use compounding, but generally speaking, they don't have the same stringent process as FDA-approved options do, and there can be some issues with safety or dosing between batches. And I don't know if there's any prescribers here, but the typical dosing we use for estrogen, if you're going to do a pill, would be on a low end, 0.5 milligram up to 2 milligrams. Transdermal is 0.025 milligrams for a patch is the lowest dose. So the translation is basically half and then 10% of that, if that makes sense. So if I were wanting to get someone from an oral option to a transdermal and they're on 1 milligram, I'd probably put them on a 0.5 milligram patch. Progesterone is usually 100 to 200. If you by chance have a patient taking this and they are taking it in the morning, that's not considered ideal because it can help with sleep and make you groggy. So it's best to take it at nighttime. And then testosterone is normally given at 1/10 the male dose to start. I just want to cover some common misconceptions about hormone therapy. One is you can't start until your periods stop. Silly, because for most people, the symptoms are the worst leading up to menopause. Granted, we don't have any guidelines that specifically say you can treat in perimenopause. We also don't have any that specifically say you don't. And with the fact that the earlier you start, the safer it is, I think it makes a lot of sense to start whenever the symptoms appear. Another is that cancer survivors can't use estrogen. Actually, the American College of Obstetricians and Gynecologists came out in 2016 saying that breast cancer survivors can use vaginal estrogen. There's no increased risk of recurrence. And then other type of cancers, for the most part, don't have any negative association with estrogen whatsoever. And another is we don't need to even think about menopause. You're not old enough. That happens a lot to my patients in their 30s. But actually about 3% of women experience menopause by the age 40. And about 12% are in menopause by age 45. So it's really not appropriate to brush this off because, as I mentioned earlier, it can be a major medical condition when you go into menopause early, and it really needs to be evaluated and treated. And then the other big one is that there's a certain age when you need to stop hormone therapy, and that's a misinterpretation of the study that if you started hormone therapy beyond age 60, it's less favorable or more dangerous, but there's actually no research showing that there's a particular age where hormone therapy becomes more dangerous. Assuming you started it earlier in life, you can stay on it as long as you have symptoms or as long as you want to, or if you are taking it for bone health, you really should stay on it because if you come off it, you're going to lose those benefits. There is some research showing that if you're on it for more than 5 years, maybe that's a higher risk of breast cancer if you have the combined hormone therapy, estrogen and progestin. A really big study came out this year looking at over 10 million women on Medicare. So they were all over age 65. And it looked at those who were on hormone therapy, so presumably staying on it from closer to age 50 versus those who are not on it. And once again, those only taking estrogen, it looked a little more favorable, lower risk of death, breast cancer, lung cancer, colorectal cancer, heart failure, blood clot, arrhythmia, heart attack, dementia. Those taking both estrogen and a progestin had a higher risk of breast cancer once again, but a lower risk of endometrial, ovarian, and heart complications. And basically, because of the benefits to your bones and your heart and risk of diabetes, you can make a really good argument to stay on hormone therapy beyond age 65. I want to talk specifically about local estrogen. So a lot of women, or a lot of people who take systemic hormone therapy, still don't have their genitourinary symptoms relieved. So that would be vaginal dryness, burning, itching, urinary frequency, frequent UTIs. So there's no reason you can't do both a local estrogen and a systemic estrogen. Or you can use local estrogen alone for someone that isn't a great candidate for systemic estrogen. And it can really help reduce the risk of recurrent UTIs. So for me, having worked in geriatrics and seen a lot of women in nursing homes with these recurrent UTIs, and we keep throwing antibiotics at it, and then they become resistant to a bunch of different antibiotics. So it really is a big cause of morbidity and mortality in that age group. So local estrogen can be life-saving. If local estrogen is not top of line for someone for whatever reason, then there are some alternatives. There's actually an oral pill that is related to estrogen and specifically increases estrogen in the vaginal tissue without affecting the breast. And then vaginal DHEA. So DHEA is kind of like the parent hormone of estrogen and testosterone. So it can help activate both of those receptors. And there are a lot of testosterone receptors in the vulva, in the clitoris, in that area. So that's a nice choice. I think about it particularly in someone that's having like a decreased sensitivity, less powerful orgasm, things like that. And then finally, the non-hormone options for treating hot flashes. Once again, the Menopause Society came out with a guideline for this. This was just last year. And they gave only 5 things, their stamp of approval with level 1 evidence. And then another got a level 1.5. I don't know what that is, but cognitive behavior therapy for hot flashes as a level 1 evidence. Hypnosis, that's why I personally got trained in hypnotherapy. I thought that was really interesting. Most of the studies for hypnosis for hot flashes looking at breast cancer survivors, and that was kind of the same group of people that I had in mind. Certain antidepressants, so paroxetine, citalopram, escitalopram, venlafaxine, and desvenlafaxine are the ones that have the best evidence to treat hot flashes. Gabapentin, that's a nerve pain medicine. It can help with sleep. So that can be a nice option for someone that's having trouble sleeping. Fezolinetant, that's the new medication that just came out last year that's affecting certain peptides in the brain, and it can kind of work directly at the brain level to help with hot flashes. And then oxybutynin is a medication we use for overactive bladder and urge incontinence. So if someone has that issue and hot flashes, I might think about that one. And I just want to mention briefly that if you have someone that's in perimenopause and we're thinking about hormone therapy, we also have to ask, first of all, are you okay with getting pregnant? Because menopause hormone therapy does not prevent pregnancy. It's to a physiologic range of a 20 to 30 something. So if you're okay with getting pregnant, great, we can do menopause hormone therapy or any of those non-hormonal options. But if you're not okay with getting pregnant, we have to think a little bit further. So a lot of primary care providers will just throw you on a oral birth control. And that actually works for a lot of people because it is replacing estrogen and progestin. But it's at such a high range that it's shutting down your own cycles. So some people feel great that way, others feel like crap, and it shouldn't be the only option. You can use any contraceptive that you would like, let's say maybe a vasectomy plus menopause hormone therapy, or actually a progestin IUD can do the work of protecting your uterus so that you only need estrogen on top of that. So that's a nice option too. And then, of course, you can use any of those non-hormonal options with whatever contraceptive you'd like. I wanted to talk a little bit about different diverse groups in menopause. So there have been some studies looking at ethnic diversity in menopause, finding that Black women are more likely to report hot flashes, depression, and sleep disturbance. Latina women are more likely to report anxiety, depression, sleep disturbance, hair and skin changes, vaginal discomfort. Asian women are less likely to report hot flashes and depression, and Indigenous women are more likely to report pain with penetration and with sex. So this is really interesting. I did see another study looking at Asian and white women in Hawaii. And once again, the Asian women reported less hot flashes, but when they put monitors on them, they had the same number of hot flashes as the white women. So it's unclear, is this, they're not feeling it? Are they forgetting it? Are they just interpreting it, that sensation, differently? And as you can imagine, since cognitive behavior therapy and hypnosis do help with hot flashes, there's definitely is a mind-body piece to this. Ethnic diversity also affects the age at which you go into menopause, with Latino women being youngest, then Black women, Chinese women, white women, and Japanese women were the oldest when they reached menopause. And of course, gender diversity can be a big piece of the menopause puzzle. So transgender and transmasculine who are using testosterone won't go through menopause typically. But a lot of them do have genitourinary symptoms from low estrogen. So you can use a local estrogen if that's the case, or pelvic PT. They should have mammograms even if they've had top surgery, because there is still some tissue remaining. And if someone is non-binary, genderqueer, and they're not on any sort of hormone replacement, then they're going to experience menopause at the average age. But it might be a little bit more nuanced. They might not find certain sex hormones affirming, even though we know that both men and women have all of them. So it just needs to be an individualized discussion. Transgender women who are using estrogen also won't typically experience menopause. They should have mammograms within 5 years of starting estrogen if they're over 40. And there's a certain goal that you should keep in mind for their estradiol level to protect the bones from osteoporosis. So as far as moving forward and support, I think many more primary care providers and OBGYNs are realizing that across the board, we just didn't get great training in menopause care. What we did learn is now out of date. So I do think more of them are really open to this discussion, and bringing in something like the menopause rating scale, the Menopause Society position statements can help move that conversation along. But if you really feel like you're hitting a wall, then a menopause specialist is a great teammate. And at least in my case, I'm always happy to speak with the primary care provider, so that if we work together for a few months and get someone on their ideal concoction, then maybe their primary care provider is willing to take it from there. And then support groups, whether that's local or online, counseling and therapy. Of course, you guys got this piece, and definitely reach out to me, Vanessa at phasesclinic.com. If this is a particular interest of yours, I keep a long list of referral sources for my patients who need a little bit more help than what I can provide. As far as finding a menopause specialist, if they can't see me or might not live in Washington, there's several websites that are helpful to find a menopause specialist. And there's actually quite a few telemedicine providers now that work in most states and may or may not take insurance. Okay, we've reached the end. We have about 10 minutes for questions, and I encourage any questions.
Vanessa, do you mind explaining a bit about the relation with hot flashes and like therapy and hypnosis? That's a new concept to me. I've never heard that before.
Yeah. There have been studies looking at brain changes with hypnotherapy, not specifically though with hot flashes, but that's probably a piece of it, is that it's actually changing, down regulating in the brain where the hot flash is originating. But I think maybe a larger piece of it is changing the top-down processing of how you relate to the hot flash, the catastrophizing piece of it. And I think that's probably where cognitive behavior therapy helps as well, the reframing piece. So with hypnotherapy, you're getting someone into a calm, relaxed, trance-like state where they're a little bit more open to suggestion. So you can use that opportunity to create new associations. So let's say every time you hear cool and refreshed, you imagine that you're floating in a pool of cool water or whatever. You just kind of create these shortcuts that can help in the moment. And I'm sure that more traditional therapy can do a lot of the same thing.
I will just say from personal experience that it can really work just to change your sense of what the hot flash is, if that makes sense.
Mhm.
And just to kind of and clients we've talked about this together, is just sort of having a moving toward it the way we would encourage people to do with anxiety or any other kind of difficult feeling.
Mhm.
And sort of like wonder at the body, like, whoa, that is a lot of heat that I'm generating. And something about that seems to help make them less painful. I don't know. So I know some people too who label them like, oh, I'm having a power surge, or, like I'm amazing. I'm producing this, whatever it is, this
I like
magical.
that.
So that seems to help too.
Superhero moment.
Yes.
I have a couple questions, but that makes me think, Emily, I'm curious, Vanessa, how many symptoms, when someone comes to you, how often are you, I don't know how to phrase this. I think as a therapist, I'm often thinking, what is something to accept and embrace? And what is something where we're really
Mhm.
like, oh no, we're advocating for change? And how often are you, I don't know, are you helping people kind of find a balance with that, given that, oh, we are aging, this is a process
Yeah.
that's really normal. There are things
Yeah.
that are lost, in this time. You won't have a period anymore. There's a fertility, there's, I don't know. So I'm kind of, how much of, I said that that's my wrestling sometimes, is how much, where are we stepping towards, oh, you're sitting with a discomfort or a pain that you don't have to live with, versus this is
Mhm.
this is really normal and a piece to kind of, I don't know, embrace. So does that
Yeah.
make sense?
Yeah. Yeah, no, it does. I mean, by the time people find me, they're very interested in treatment, I think. But I think, yeah, helping someone through the transition, um, sometimes that self-doubt, self-hate, that can be really an integral piece. That's what I often think about, right? I might think about adding hypnotherapy, or if I have someone that I think is catastrophizing and really feeding into their symptoms
Uh-huh.
by hyper focusing on it. I think hypnotherapy or other therapy can be really helpful for that piece too,
That makes sense.
and
And
pain also.
yeah, well, that's what just the discomfort and the pain, it seems like that can go along with, and then just this shift in your identity. I thought I knew my body in this way, and now it's something different. And I loved your note about self-compassion. Um,
Yeah.
Pragmatically, I'm curious, are there any contraindications with someone on an SSRI and hormone therapy? Are you ever careful with that, with combining anything like that, or?
Yeah, you can combine them.
Okay.
I have plenty of patients that combine them. If someone is um, taking an SSRI for menopause because they are a breast cancer survivor, then there are certain SSRIs that you need to avoid with certain breast cancer treatments, but not specifically hormone therapy.
Okay. Thank you.
And also something like the fezolinetant, if someone's hot flashes aren't fully treated by
Uh-oh. Is that just me? Or is that okay? I bet she'll be back. We'll see. Oh, Vanessa, we missed you for a second. Rose, it seems like you're back.
Okay.
What were you saying?
I was just
Sorry,
saying,
that last little bit.
I can combine hormone therapy with another treatment if the hormone therapy isn't treating hot flashes fully, but we've reached our ceiling as far as causing side effects from the hormone therapy. So maybe hormone therapy plus antidepressant or plus gabapentin.
Okay.
I just really wanted to express my appreciation, Vanessa. I work with so many clients who have shared with me like really discouraging experiences with medical professionals. And so I find this so affirming, and I just really appreciate being better resourced myself in order to help them advocate for themselves. Because I really hear a lot about increased anxiety and insomnia and various other issues, but really a lot about anxiety in particular, and a kind of lack of what seems like maybe some limited awareness on the part of the medical professionals that they're seeking help from. So thank you so much for this.
Yeah, I know. And I certainly never learned in my nursing program that menopause can cause heart palpitations. You know, I'm sure so many women have gone through such expensive and extensive workups only to learn maybe after the 7th provider that it was just menopause.
I actually, that's so ironic. I had someone just yesterday tell me they'd been to 3 providers and worried about, heart failure, heart disease, and then found out for menopause. And it was what they were noting was it was 3 female providers, PCPs. And just, kind of speaks to that lack of, I mean, for us too, right? I mean, in mental health, I personally never had anything in grad school around a lot of sexual health issues aren't covered, I think, but this in particular. I have a question. I know we're almost out of time. For someone that is curious if they're entering menopause, I don't know, one ND had mentioned that they kind of recommend an FSH lab. Is that kind of a first line of questioning there, to check those levels? Or what do you tend to recommend if someone's just curious, am I entering menopause? Am I in menopause? What's the lab?
I personally don't check labs. Sorry. I just got this tickle in my throat.
I know. Thank you for doing this while you're sick. I really appreciate that.
As I had mentioned at that early slide, how the levels can really go up and down so much. You can get a level back that's perfectly normal and it doesn't rule out perimenopause. So a lot of times it just makes things more confusing. So I do use labs if someone's not getting periods. Maybe they had a hysterectomy. And maybe that's a time to check labs to see if they're now in the menopause range. But otherwise, it's symptomatic.
Okay.
It's a clinical diagnosis.
Okay.
There are some measurements of how many ovaries you have left. So that can be useful if it's a fertility question. But it's not really used to diagnose menopause quite yet anyway.
If there's time for one more question, and I apologize, Vanessa, you might have said this, but is there like an average length of duration of perimenopause before menopause has happened? I know it's just that one day, but is there an average?
Yeah, the average is around 7 years. I use the ballpark 5 to 10 years. So as you saw earlier, the menopause can start from 45 to 55. So it's really not that uncommon to have someone in their 30s that is symptomatic, regardless of what their primary care provider might say.
Wow. Well, I want to honor your time. Vanessa, this has been incredible. I agree, Emily, with what you said. I just feel so grateful for honestly your years and years of study and the immense amount of research you've done to share with us. I know, a very broad overview of all that you've learned, but and that we now have you as a resource makes me really grateful because I think,
Well,
it's really special.
Thank you for having me. And as I said, if any of you are particularly interested in this subset, please let me know.
I know, Emily, you had mentioned kind of some specialized training for therapists could be certified. Now I'm forgetting is it just the Menopause Society? There was something where a therapist, if we're interested, there's quite a bit of training online that relates to the mental health side of things.
I think it was the Menopause Society. Does that
I
sound
will look
familiar?
and add it in
Yes.
the video. I'll put it with the resource with Vanessa's name and resources. I will find that. So if any of you are interested in really doing a more study related to our work, there's a certification. You can be listed on their website, that kind of thing. So
Yeah, it might be the Menopause Society. That I'm a Menopause Society certified practitioner, but you don't need to be a NP or MD.
okay. So a great resource
It's
also
just-
for us to look for folks, it sounds like.
It's
Lovely.
very heavy on the primary care, I would say.
Okay.
Definitely goes into mental health also.
Okay. Well, I'm so glad you listened to that podcast and had your lightning moment a year ago.
I know, right?
So excited for you with Phases Clinic. That's really exciting. So happy to have you as a referral and just such a great resource for us. And personally, just I'm really grateful. Appreciate this information. So
Yeah, thanks for hosting me.
yeah. Well, have a wonderful weekend, everyone. I'm going to stop the recording now. Love being a woman. Here we are. So many great changes across our lifespan. I love your rephrase, Emily. Just all the power that we can
Power surge.
power surges. Okay, well, lovely. Thank you so much for your time. And I will share the video with all of you and we can share it with our people too. Yeah, Vanessa, obviously feel free to use it as you want to too.
Yeah.
Lovely. Well,
Awesome.
thank you so much.